Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville and I will be serving as your program facilitator and will present your questions to our panel of experts. This evening, Jefferson Health experts in bariatric medicine and bariatric surgery will answer your questions about weight management options. Well, thank you so much for submitting your questions in advance. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And finally, due to hospital guidelines and privacy, we are unable to comment on specific cases. Well, with that, I want to go ahead and introduce our experts for the evening, starting with Dr. Mark Neff with bariatric surgery, Erica Carver, a nurse practitioner in comprehensive weight management, and finally, Jocelyn Baumgarten, a registered dietitian. Well, thank you all so much for joining us. Before we dive into the questions, which I know we have a lot, so we will get there shortly, I'll just give each of you a minute or two to say hello, provide some background information about yourself, and then we'll get started. So, Dr. Neff, why don't we go ahead and start with you?
Hello, everyone. My name's Mark Neff. I'm a 55-year-old diehard Eagles fan and a Phillies fan. I'm wearing my Phillies tonight. I'm fellowship trained in minimally invasive and bariatric surgery. I was trained by Robert Brolin, past president of the American Society of Metabolic and Bariatric Surgery. I know that's a mouthful. And I'm a surgical descendant, meaning that in my training, was Dr. Michel Gagne, who was the originator for the sleeve in the United States. I've been doing surgery here in South Jersey since 2005. I'm the founder of our weight loss surgical program, and we're about to hit our 6,000th case next month.
Wow, incredible. And I love how you started that off with sports. So thank you. All right. Next up, Erica.
Well, I'm not going to start with my age, but I'm Erica Carver. I'm one of the nurse practitioners at our comprehensive weight management team. Before I took this role, I did work in primary care at one of our Chalfont offices for Jefferson. And like early on in my career, I was a registered dietitian. So, to me, this comprehensive weight management is so special because it really brings like food and medicine and like that long-term health care. So I'm excited to be here today.
Yeah, we're excited to have you. It'll be a great discussion. Okay, and finally, Jocelyn.
Yes. Hi, everyone. My name is Jocelyn. I am a registered dietitian. I have been practicing for almost 10 years now, and I specialize in weight management and also lifestyle medicine. I always say that I have a very strong passion in helping people understand that all foods can fit into a healthy diet. And even though we are here to talk about weight management, I also like to stress that there's a lot more to our health than just weight. So I'm sure all things that we're going to dive into tonight.
Exactly. All right. Well, without further ado, I think we should go ahead and dive in. I know we have a lot to get to. So to kick us off, Dr. Neff, I will turn to you for the first question of the evening. And that is, what are the eligibility requirements for bariatric surgery?
So I'm going to break this down into the specific requirements that everybody knows, and then Dr. Neff's three additions. For insurance purposes, you have to have a body mass index, a calculation based on your height and weight of 35 to 39.9, with a severe comorbidity related to being obese, things like severe obstructive sleep apnea, refractory high blood pressure, diabetes, heart disease, or you do qualify for your insurance purposes if your body mass index calculates to 40 and above. But that's the insurance purposes. Over the years, I would offer that I've added three more to this. The first one, very simply, you have to be prepared to make that complete lifestyle change forever. Number two, you have to understand that surgery is just a tool, And then the third is you have to have the proper support, family, friends. This is a challenging, both mentally and physically, process to go through. So it's more than just qualifying for the surgery. It's, having Dr. Neff's 3 additions.
Okay. All right. Thank you for walking us through that. Okay, Erica, we will turn to you next. How can patients manage common challenges such as emotional eating, cravings, or even weight loss plateaus?
Yeah, I think there's kind of a lot to that question, and I think most important to recognize, and it goes back a little bit to what Dr. Neff said, is it's not just about one thing, it's really about the toolbox, that comprehensive approach. And all those items there talk about behavior, they talk about stress, lifestyle modifications, and then like medical management. If you break it down into each sort of area, so like emotional eating, it's not lack of willpower. Oftentimes it's learned coping strategies for patients. So, or for individuals, like we think about stress or boredom. We often like emotionally eat if we're tired or even if we're celebrating. So that can trigger some of our brain's like reward systems. And so I like to work with patients on that behavioral aspect and say, okay, let's do some like pause and sort of label our feelings. I always tell them to kind of say like, are you truly hungry? Or are you triggered by something? Again, doing like a 10-minute delay, kind of gives us the opportunity to sort of work through some of those feelings. And then I always say having like something in it, like coping, non-food stress release sort of coping things that you could do in place of when you're doing that emotional eating can be like very impactful. You said, and as far as like managing cravings, this is one I hear all the time in my practice. And that one's a tricky one because we see it often impacted by blood sugar fluctuations, patients have being sleep deprived. Some patients are very restrictive in how they're dieting or how they're eating. And then sometimes, that reward center that we talked about can be from like highly processed foods. So all of those things can impact some of that cravings that we feel. So in our practice, we talk a lot about prioritizing protein, working on that and like how we're eating and what we're doing, not over restricting. Cravings can be managed if we like plan for indulgences. So like instead of just saying like, okay, every night I'm eating, after I get done with dinner, I want a snack, I want to sit on the couch. We'll make a plan for it. So we talk about that a lot too for our patients and just kind of managing those cravings. And then your last part to that was the weight loss plateaus. And again, I feel I'm not giving great answers because those are hard. They're really individualized for those patients and for those situations. I think the biggest thing that I take away from most conversations I have is that, plateaus should be a little bit accepted. It doesn't mean it's a failure. It sometimes can be a lot of different things. Yeah, sure. It can be sometimes things that we're doing. We need to optimize our sleep, reduce our stress. Or did you start a new medication that impacts your weight loss journey? Are you taking weight loss medicines, but maybe we're not taking them the right way? Maybe we need to add new medicines. So those can be a lot of causes for weight loss plateaus, but then also just metabolic adaptations. Like as we lose weight, our body kind of changes for what we need. So looking at that and sometimes your body just needs some time. I think that's the hardest thing that I hear for people in clinic that I see is that your body sometimes just needs several weeks to adjust before it will allow you to have some weight loss. So again, when I talk about it, I just say, okay, let's take that time to sort of reassess like how we're eating. Are we getting enough protein? Let's look at our behaviors. Let's focus on like non-scalable victories and like expect some of these fluctuations and avoid that shame-based thinking. A lot of times people are very feel defeated when they have that plateau, but really I like to move away from that. And if you have that, seek support, right? I want those people or those patients to come to either me or nutrition or, our behavioral counselors, something to work on that because two heads can be better than one, I feel like, in weight loss plateaus. And I see that all the time. So those are my big ones.
That was great. And I think your answers were incredible. So great job. I know I threw a lot at you in one question. So thank you. I think it's just a reinforcement of, there's no one size fits all approach. Okay, but thank you. All right, Jocelyn, we will move to you now. Next question here. What should a balanced meal plan look like to support weight loss and overall health?
Yeah. So Sarah, you just set me up. You just said that no plan, it's not one size fits all. And that absolutely applies here along with a lot of what Erica was just saying. So I generally say that a meal plan by itself usually isn't necessary in the traditional way we think of a meal plan as having, 5 days a week, a breakfast, lunch, and dinner, and you should only be eating X, Y, and Z. That rarely works. So instead, I really encourage people to focus on a balanced approach where we're consistently including our key nutrients at meals. So, especially with a focus on protein, fiber, and healthy fats. So, if we can include all of these food groups, then we can ensure we're going to satisfy our hunger, which Erica started to touch on, and I'm sure we're going to talk about a lot. A meal that leaves you hungry in an hour isn't going to help you meet your goals. It's going to lead to grazing and mindless snacking later on. So we want to eat. It's not about just eating less. And I'm going to talk plenty about that, I'm sure, tonight. And the other reason why I don't prescribe rigid meal plans is because our life isn't rigid. So you might be traveling, or you might have to eat dinner earlier because you're doing a webinar tonight, or any of those things that affect how you're going to eat. And so if you have more of this outline of how can I get in protein, fiber, and healthy fats versus having a strict meal plan that you're trying to follow weekly, that's going to help you be a lot more successful. So instead, we really want to just focus on putting these building blocks together. So, we think, okay, what am I going to do tonight? I have a really busy night. I don't have time to cook. Well, maybe I'll pick up a rotisserie chicken. Okay, that's my protein. And okay, I want to get some, carbs in there and some fiber. Well, I'm going to do an instant pack of the brown rice. I'll do it with a side salad. Can I get some healthy fats? Oh, I'll throw in some avocado and some nuts in there. And just like that, A, B, and C, I have all my building blocks. Shouldn't take too long, shouldn't be too expensive. And it was something I chose today, and that I know I'm in the mood for it.
All right. Thank you. I think that flexibility element is a nice reminder. So thank you. Okay. Before we go to Dr. Neff, I just want to put out a reminder. Feel free to drop any questions in the chat as questions are popping up for you during our discussion, as we'll get to the live Q&A in a little bit. But for now, Dr. Neff, I will turn to you for this next submitted question. What is the expected recovery time after bariatric surgery?
Thank you, Sarah. So this is a very common question I get asked at the clinic, and I break it down into a physical recovery and a mental recovery. The physical recovery, I think, is easier. You'll stay overnight in the hospital for a sleeve, 2 nights in the hospital for a bypass, maybe 1 or 2 nights for a revision, and honestly, you'll be cranky for about 3 to 5 days afterwards, depending on the surgery, needing some pain control afterwards. And then there's a gradual return of strength as we gradually advance your diet from liquids to mush to lumpy food to real food over a period of about 4 to 6 weeks. Um, the mental recovery, I think, is much tougher. These operations basically press reboot on your internal computer, and we wipe the memory clean, and you have to learn things all over again. How quickly to eat, how much to eat, types of foods to eat, drinking habits, stress management habits, shopping habits, cooking habits, relationship with family and friends. I think honestly, that's about 2 to 3 months before it really fully clicks. And some people, it even takes longer. They have to make it through all the holidays of the year. They have to make it through all the seasons of the year. We have a very intensive follow-up with patients, roughly about 10 visits that post-operative period of time, that first year, between me, the nursing practitioner, the dietitian, and now our newly added clinical social worker to coach people through that mental recovery.
Okay. All right. Thank you. That's an important call out, because I think a lot of people obviously expect the physical, but maybe not necessarily think about the mental. So thank you for making that call out. Okay. Next question here, Erica. How do injectable weight loss medications compare to oral medications in terms of effectiveness and safety?
So I think what's really great about the weight loss medications is that the side effect and safety panel it's pretty low. It's really manageable for most patients. Of course, there are side effects. There are side effects with every medications. As far as, contraindications to injectable medications, we do not prescribe injectable medications. So that's the GLP-1s, GIP medications for anybody that has a medical diagnosis of medullary thyroid cancer or multiple endocrine neoplasm type 2. Total mouthfuls, very rare forms of cancer. So if you yourself or an immediate family member has those diagnoses, we don't prescribe them. But to be honest, those are the biggest contraindications. Almost any other patient, we can work with different medications as far as what would be appropriate for them. We make sure that we work on a slow, trying to limit some of the side effects and symptoms for patients based off of how they're feeling and what they're doing. But as far as like safety wise, it's really showing that these medications are pretty safe and low side effects for them. We know injectable medications do have a greater weight loss potential. There is that like 15 to 20% total body weight loss with injectable medications. Whereas oral medications, not including the new Wegovy oral pill, but the other oral weight loss medications have about a 5 to 8% total body weight loss. But oral medications can be a good option for patients because, many patients, as far as like price, and then they are needle-free options because there are patients that prefer not to utilize any injections, and they can be really helpful to kind of work with that whole comprehensive aspect that we've started to sort of touch on. That's important as well. So I think overall they're pretty safe, well managed, but of course it requires like that discussion with yourself and the provider and reviewing your medical history before you can make a specific recommendation for it.
Absolutely. Talk to your provider. So thank you. Okay. Next question here, Jocelyn. How does metabolism affect weight loss and can it be improved?
So metabolism is very complicated. If we want to simplify it for the purposes of tonight, we can think of metabolism as how your body is turning food into energy. And when it comes to weight loss, metabolism is going to play a part, but not necessarily as much as people tend to think. I get a lot of patients coming to me thinking that it's just their metabolism. This is why they can't lose weight. And we tend to forget about the factors that affect that weight loss and our metabolism most, which is muscle mass, sleep, activity level, stress, and then also a history of chronic dieting or yo-yo weight loss when we've been dieting for many years and our weight goes up and then our weight goes down and our weight goes up and down. That does really affect our metabolism. So what's really important to understand is that when we severely restrict calories in any way, many diets out there will have us restrict calories in some way, shape, or form. Your body is going to adapt. Our bodies are really smart. And so you cut calories, you lose some weight, but then your metabolism does slow down. And then it's going to react by making you hungrier and making you crave foods, usually foods that are high in sugar, foods that are high in fat. And that's our survival response. And so to support our metabolism, instead of just trying to drastically cut calories, it's often much more effective and sustainable to focus on things that help the metabolism. So consider strength training, making sure you're getting your adequate protein, practicing good sleep hygiene, managing your stress, and avoiding this chronic undereating. So you'll notice that all those things I mentioned are not quick fixes, and they often are hard and they take time. But those things are actually more likely to boost our metabolism, they're not quick fixes to boost the metabolism, but they're going to focus on helping your metabolism long term.
Okay. All right. Thank you. Some helpful things to keep in mind there for long term. Thanks. All right. Dr. Neff, going back to you here about surgery. So what happens if someone regains weight years after bariatric surgery?
Thank you, Sarah. And I think that Jocelyn set me up nicely for this one because the truth is weight fluctuates over a person's lifetime. All those factors that Jocelyn talked about, muscle mass and stress and sleep and medical conditions, the metabolism changes as we get older. Addition of medications can impact upon our appetite and our metabolism, new stressors, jobs, relationship, kids, changes in exercise habits, injuries. So I think if we're being honest, to do a surgery once on a patient and expect it to last for 30 to 50 years isn't really, being accurate. What we need is we need to encourage the patients to be coming back and working with us here at Jefferson, whether it's Jocelyn and working with dietitians long term, whether it's working with Erica and the addition of medications. We have wonderful medications now, and so when a patient has weight regain years later, I often start with just the multidisciplinary approach. Let's get you back to a dietitian. What are you doing for your diet and exercise plan? Let's check your blood work. Let's review your medications. Let's try a medication. And I very much think of a patient who recurs with their obesity, much like a patient who has a recurrence of a cancer. Like they've been a survivor, they've been doing their follow-up with the oncologist, they have a recurrence. Well, now it's the whole multidisciplinary approach. How has it recurred? Where has it recurred? What stage is it? How best to treat it? I think that same cancer analogy is now being applied to treating patients with the disease we call obesity. What's not working? How best do we fix it? And go from there.
All right, absolutely. And I really like that team approach. So thank you. Okay, Erica, question for you here. What are the risks and side effects of weight loss medications?
So when it comes, like for weight loss medications, I'm going to break it down into like that oral medications and then injectable medications and kind of talk like overall. When we think of our oral medication options that are available, we think of things like phentermine, Qsymia, Contrave. Those are like the bigger ones. There's obviously metformin we utilize a lot for weight management also. The biggest side effect that I see from a lot of those oral medications is constipation, right? It's that GI impact, a little bit of that constipation. Like I said before, like most well-tolerated, phentermine is a stimulant. Some patients in the beginning might have a little bit of like that excess, like feeling of maybe heart fluttering or a little bit extra energy, I call it, in that first little bit. But again, we recommend starting very low, kind of trying to mitigate any of those side effects for those patients so that it is a seamless transition for them if they're utilizing those. But constipation is something that can be ongoing and is something that we work through and talk as well. When we move into our injectable medications, so those are things like our GLP-1s, our GIPs, so Wegovy, Saxenda for weight loss, or Zepbound. We see more of that, common GI side effects of the nausea. That's the biggest one I hear. I do hear constipation from that one as well, but you can have abdominal cramping, a little bit of diarrhea. Some patients have some vomiting, but again, it's about trying to avoid those side effects and symptoms. So we work really well with our patients about, going very low and slow and making sure that they're eating and staying hydrated and, give them tips and tricks to make sure that those don't become a part of their journey on with the utilization of the medicines. Very rare, but is a serious side effects that can happen with the injectable medications. Again, less than 1%, and those are patients that use the medicines for diabetes, but they can also use these medications for weight loss. There was again, less than 1% pancreatic issues, some gallbladder stuff. Again, we talk about hydration, how to eat, what to eat, all that to sort of avoid it. But that's like the big sort of side effect that people will hear about and then, have concerns. But besides that, pretty well tolerated. And we try to work through some of those GI symptoms as best we can, utilizing the nutrition and hydration and any tips or tricks that we have for patients.
Okay, great. Thank you. And a good reminder to continuously work with your provider. All right. Jocelyn, question for you here. What are the most common nutritional mistakes people make when trying to lose weight?
Okay. So I am a stickler for language, and because losing weight is so hard and so out of our control in many instances, I never label people's inability to lose weight as a mistake. So if you are sitting here and saying, "What am I doing wrong?" You're not doing anything wrong. Weight loss is incredibly complicated. It's why all of us here on the panel today have jobs. So I always start with that. But one thing that I do see time and time again that we've already, hinted at or spoken about really is that people try and ignore or run away from their hunger when they're trying to lose weight. And that seems logical. Trying to lose weight, I should eat less. You've probably even been told that before. But when that's the only thing that we focus on, what tends to happen is we'll eat very little during the day. So maybe we'll have just 2 eggs for breakfast and then just a salad for lunch. And then we're going to have just a piece of salmon with some veggies for dinner, right? We're doing perfect. We stuck with our diet all day. But then what happens, right? We usually sit on the couch, we're winding down, and we start looking for food, right? We grab a handful of popcorn here or a spoonful of peanut butter there, and that spirals, and we start grabbing cookies and chips and anything we can do. And then we blame it on ourselves and we say it's emotional eating, it's stress eating. Why can't I stick with my diet? But then when we turn and look at it, maybe we only had like 500 calories during the day. Maybe we didn't get anywhere close to our protein goals. And what we're dealing with, yes, there may be emotion behind it, there may be stress behind it, but at the root of it is probably just real biological hunger. And when we let ourselves get so hungry, Erica mentioned the hunger scale earlier. So if we think of a hunger scale from 1 to 10, with 1 being absolutely starving, and 10 being so full, when we let ourselves get to 1, we are almost always just going to swing in the opposite direction to 10. And I call it my chicken finger hunger. So that's what I want. I just want chicken fingers when I get to a 1. Other people, it's ice cream, right? We all have that food. So a dinner, I'll give my example today. I ate very early. I ate at 5:30 today because I had this and I made myself, I don't know, some chicken dish and it was good. If I had waited until after this webinar to go eat that, I would have turned up my nose at it and probably ordered a pizza because I would have gotten so hungry. So being healthy, eating nutritious foods doesn't mean we have to eat food that doesn't taste good. It can be delicious and yummy. But a lot of times if we're letting our hunger drop too low, we're only going to have those cravings for the high fat, for the high sugar foods.
Okay, that was very helpful. I really like the analogy of the chicken finger hunger because that makes a lot of sense. Yeah. And also I like the acknowledgement of maybe not using the word mistake. So just thinking about that language too. So thank you for that call out. Okay. All right, Dr. Neff, back to surgery. All right. How often do patients require additional procedures after their initial bariatric surgery?
Sarah, so I'd like to break this down into like what we typically see after these surgical procedures, but I also have to be honest that there are some new recommendations coming down from the national organization that I'll get to in about 60 seconds. Specifically requiring additional procedures. So about 10% of patients do pursue some sort of plastic surgical procedure, whether it's excess skin in the lower part of their belly or excess skin inside of their thighs. Some of these procedures can actually be covered by insurance companies if you do prove that you're medically suffering from the excess skin. And that comes usually about 1.5 years after the surgical procedure. There are patients that do require surgery for refractory reflux disease after sleeves, patients that do require surgery for weight regain, and that's about 15 or 20% when you include refractory reflux, weight regain. And then there are people that do require surgery because of complications of the original surgery, or maybe they've misused the surgical tool that we've given them. Some people do develop ulcers after these surgical procedures from smoking or drinking, or do develop strictures. So overall, if you add all these things up, I would say probably 1 in 5, 1 in 6 patients is going to have some additional procedure after their initial bariatric surgery in the patient's lifetime. Now, the new recommendations, there are several authors in our big organization that are suggesting that in addition to our routine blood work, we start doing yearly endoscopies on patients after these surgical procedures to look for silent reflux, to look for problems like early ulcers and early strictures, and to look for complications that can be treated endoscopically before they actually become, true surgical issues.
Okay. All right. Thank you. Good to know about these latest guideline updates. So appreciate the news there. Okay. Next question. Erica, how do hormonal changes such as menopause or PCOS affect treatment options?
I feel like I could talk about this for a whole hour itself. But really the bottom line is that hormones like menopause, like hormonal changes like menopause or PCOS, they do change our biology a little bit. And I hear so much from people, they come in, they're like, I've changed nothing, diet, exercise, everything. And all of a sudden, my the women are telling me about their central obesity, or all of a sudden they gained all this weight. And what is it? And it's really because it's not lack of effort. A lot of times it's because these medicine or these hormonal changes do alter some of our insulin sensitivity. It changes our muscle mass. It really does start to affect like some of our appetite signals as well. And again, this is one of those moments where it's not that one size fits all, and it's more about tailoring strategies that work to kind of during this hormonal shift, like to work with them and not against them. So as a general rule, I often like recommend to patients to increase their protein intake, sometimes a little bit more than the average that I say for patients not in this phase or not with these diagnoses. I always say like a little bit higher protein intake, focusing on that strength resistance training. And we do add medications at times when it's appropriate, utilizing things like metformin or GLP-1, GIP therapies. They can all be really effective. It's just that, treatment just really has to be a little bit more personalized during these times. And again, it's getting away from some of that, talk in your own head that it's your fault or it's something you're not doing, or that negative talk, like it's your body changing or it's your body with its hormones. And so I always want to empower all the women and just say like, please, we'll work through this. But a lot of times these hormone changes make it where we have to just add a couple or change a few different things from what we maybe were doing in the past that worked for us.
Okay. All right. Yeah, definitely shifting the mindset. So thank you. Okay, a few more submitted questions here before we turn to our live questions from the audience. So thank you all for submitting your questions. I see questions coming into the Q&A box, so we appreciate it. But for now, we'll get through a few more submitted questions here. Jocelyn, this question is for you, and I think we've touched on it a little bit, but would love to hear your thoughts more. So this question is, what role do portion sizes and calorie intake play in weight management?
Yeah. So I probably already driven the point home a little bit that, I don't love the calorie counting option. But let's talk about that a little bit more. So calories are not all created equal. We could stick to a 1,000 calorie diet a day and be only eating ice cream, right? We could do that. We could eat 1,000 calories of ice cream every day and still be only getting 1,000 calories. That doesn't mean it would be helpful for us. And the other reason why I really don't love counting or focusing solely on our calories is because it takes us out of what we were just talking about with our biological hunger and paying attention to our body signals. So if you are just focused on counting calories, well, what happens if you get to the end of the day and you're trying to eat 1,500 calories and you've hit 1,500 calories and you're hungry? Well, what do you do, right? Most of you will say, I'll try not to eat, right? But then that pattern that we just talked about, that's going to happen, right? We can only have willpower because it's not really willpower, it's our body fighting back on us. We can only resist that for so long. And then what happens if we, get to the end of the day and we're at 1,200 calories and we're not hungry, but we have these 300 calories left? many of us are going to eat something, even though we're not feeling hungry. So it can work both ways when we're just focused on this external factor, not on our internal factor. And the same kind of goes for portion sizes. We have lots of different models, and there are portion sizes on packaged foods. And yeah, for ultra processed, high sugar foods, things like chips and candy and cakes, it's probably helpful to it is helpful to limit those foods, right? I don't necessarily recommend, sticking with the portion size on the box. That's usually kind of arbitrary. But certainly doing things like not just eating directly out of a container and not eating while we're in front of the TV. I tell people all the time, like, you want that ice cream or that snack after dinner? Great, eat it at the table and put your phone away. And a lot of sometimes people say, I don't even want it. So, things like that, great. Yes, let's limit things in that way. I don't really think there's any point in limiting foods like protein and fiber. I've never really heard someone come to me and say, I get out of control when I eat chicken, or I get out of control when I eat eggs, right? So why would we limit it to a quarter of our plate, which is honestly what our national guidelines, have said. So if you're hungry after dinner, have another piece of chicken. I think it's more about just listening to our hunger, getting in tune with our body. And you won't crave those other ultra processed foods as much if you're nourishing your body with your protein, fiber, and healthy fats.
Okay, very helpful. Thank you. All right, Dr. Knapp, we will turn to you. Another surgery question here. What complications are most common after the first year of surgery?
I think that the most common complications we see are probably nutritional deficiencies. We check the vitamins before the surgery is ever performed. We check it routinely at 3 months after surgery. We'll check it again periodically if the patient's exhibiting any signs or symptoms of a deficiency or worried about a deficiency. But then we do it yearly thereafter. And I think the most common one we see is a vitamin D deficiency. After the vitamin deficiencies, nutritional deficiencies, I would say infections or irritations in skin folds in redundant skin that patients have. While they may be more comfortable in the heat than they've ever been before, there are still buildup of moisture in some of those skin folds. And then I guess the third most common complication would be an episode of dehydration. Most patients that first year, they're figuring out how quickly to eat and drink, how much to eat and drink, but they're still sort of like a newborn figuring out, how do I make it through different seasons, different holidays, different activities, different stressors in my world. And, sometimes that lack of getting in a proper amount of hydration sneaks up on a person, especially if they're exercising at the gym and they can't wolf down a bottle of water, or now they have more energy to walk the boardwalk and they don't realize how far they've gone without having anything to drink, or they're more comfortable in the heat, but they're still very active. So I would say vitamin deficiencies, skin irritations, and then an episode of dehydration.
Okay, all right, thank you. Definitely a lot to think about, so appreciate breaking it down for us. Okay, Erica, question for you here. What kind of monitoring or follow-up care is needed during a weight management program?
So I think it's a very important question, and I'm answering some of the questions in the chat, and so I'm going to kind of like circle some of those in a little bit to answer part of this. But why it's really important. So it's really not a one-time prescription, like, right? Like, you don't come in to see me and I like order you a medicine and then you go and do whatever, right? It's really about that ongoing care. And in the beginning, we usually like more frequency with our visits with patients. If I had a choice, I would see my patients every month. Unfortunately, I can't. So I see them about every 3 to 4 months, in that beginning sort of titration. And what we find in that frequent follow-ups is it really improves that long-term success, because It increases accountability, right? And it allows for those small adjustments. So I had a patient ask on our chat that was saying like, ooh, I'm on one of these injectables. I am feeling nauseous. I was told I'm supposed to go up next month, because the box says or the doctor says you go up every month. We really find in our practice that we don't adjust just based off of the direction to go up every month. We really like these allowing for these small adjustments of, based off of how a patient is feeling, how the medication is working. So, utilizing those lower doses for as long as can be effective. So that's going to require more follow-up to kind of touch base. And also the follow-up allows for the reinforcement, right? We talked about how we try to do that comprehensive approach. So when we're following up and we're talking about it and we're utilizing all these things, we can talk about the nutrition, we can talk about the behavior strategies and things like that. I set goals with my patients each time I see them. So like, what are we working on this time? What's your homework today? And that's kind of like a way that really gives us a lot of that ability to catch things early and make changes where we can. When it comes to maintenance, I got to be honest, once, patients are doing well, they feel well, we're maybe still working on goals, but they feel like confident and able to go forward. I see them about every 6 months, but again, it's based on each person individually, and what works best for them. But I think it's important to remember this is not a like set it and forget it. And I always feel really bad when I have a patient come that unfortunately didn't maybe get that sort of individualized care when they started these medicines and they had a lot of side effects and symptoms. And I would hope to not have that with my patients. So I say more often is better.
All right. Thank you. Okay. And our last question here before we turn to live questions for this evening, Jocelyn, which again, no, you touched upon, but think it'd be good to expand. How do factors like stress, sleep, hormones impact weight management?
Yeah, well, they do 100%, right? I think that's a big takeaway from tonight. But it doesn't mean that we don't often forget to take them into account. So, if we take just sleep and stress, I always like to say that these two lifestyle factors, they affect our weight in both invisible ways and visible ways. So they're doing things behind the scenes with our metabolism. Not good. But then they're also doing pretty obvious things that are going to affect our weight and health. So if we are tired, I, for one, am not cooking for myself. I'm ordering in. I am not exercising. I am sitting on my couch. I am craving cookies, not salmon, right? So those are some things that when we stop to think about it, it's like, oh yeah, when I am, when I'm sleepy, when I am stressed out, it is affecting directly how I am taking care of myself. Hormones can really wreak havoc on our weight with different disease states, different stages of life. And that's another reason why I like to take blame off of ourselves, right? There are hormonal changes that we go through, whether it's just life changes or specific disease states that we are in, that's just simply going to make it harder to lose weight. And that's why we need to focus on these other factors of health. We need to focus on how changes make us feel. Because if we improve our sleep hygiene and we start sleeping better, I'm going to feel better and I'm going to have more energy and I'm probably going to be happier. Will the number on the scale move? It might, but it might not. Same thing with stress. If I am working on my stress levels and I am trying to separate my work-life balance and I'm trying to journal more, I'm going to feel happier. Again, scale might move, but it might not. And so when we have these external factors that are just making it hard to lose weight, it can become really, really frustrating. And we can get really, really discouraged and we can want to just give up and throw in the towel. So that's why I think Erica and probably Dr. Neff have already mentioned these like non-scale victories. And so that is when you have a victory that has nothing to do with the scale, right? Like I have more energy to play with my grandkids. Maybe that involved weight loss, but maybe it just involved making some of these changes. And this is where I will also put a plug in for our lifestyle medicine program, which is a new program at Jefferson that really doesn't, it's not a weight loss program. It's a program that focuses on nutrition, exercise, sleep, stress, and social connection. People who join the program will probably lose some weight, but it's not our focus. We are focused on all of these external factors and, really focused on practical tips to help us improve these things, right? I think we've said a lot. Help make your stress levels go down, sleep better, right? But those things aren't easy to do either. And so having those practical tips can be really helpful.
Yeah, sounds like a great program. Thank you. Okay, well, that was great. Thank you. With that, let's get into the live questions because I know they're coming and I know you've all been answering them in the chat. So thank you for the impressive multitasking. I'm going to go through and ask the questions. If some of them you've already answered, I think it'll be good still to just talk about them out loud so others can kind of hear your response. This is definitely meant to be a discussion. So, feel free to chime in whenever you want and we can build on each other's thoughts before we wrap up for the evening. So with that, the first live question here, are there any medical conditions that would make certain weight management programs unsafe or less effective? Any thoughts?
I can kind of jump in on that. I think it's important to, and kind of like we've talked about through this like whole sort of discussion, is that it's truly a comprehensive approach and it's very individualized. So it's not just about medications. We talked about how it was about lifestyle modifications, nutrition, exercise, reduce of stress, sleep, all those things. And I think that's appropriate for everybody. And I think that I don't want anyone to feel hesitant that they can't come and sort of get an evaluation and work through things, because there's things that we all could use support with, and it looks different for everybody. So no, I don't think there's anything. There are some hormonal changes that we talked about, things that we have to work through sometimes that make weight loss a little bit harder even. But again, individualize, work through it, talk through it. I don't think there's anybody that isn't a right person to come and get support through the comprehensive team.
Great. Thank you. All right. Next question here. This person says, can you talk more about exercise? Is there a good way to start exercising? What about exercise when being overweight and having joint pain?
Yeah, I can talk about that. First thing I would say is always reach out to your doctor if you are feeling nervous about starting with exercise or you feel like you have a specific condition. A lot of times they can put in a referral to physical therapy. You don't need to have had a specific injury, and a physical therapist can help you to get into exercise in a safe way. And then my other recommendation is to start small. I think that so many of us are unsuccessful with being active long term because we think it has to be all or nothing. So if I'm not doing anything right now, if I exercise, I have to start doing 30 minutes, 5 days a week of moderate activity or whatever it is. And that's just not true. We actually have seen in research studies that we see the biggest benefit from exercise in those who are doing nothing to doing something. So more than the people who are doing 30 minutes and increase it to an hour, or doing an hour and increase it to 2 hours. The people who are doing nothing and add in activity see that biggest benefit. So just do something. What will make sense for you? Can you walk up your stairs more often or park farther away from the grocery store? Or can you just start to get outside now that the weather is getting nicer? Come up with a goal. We like to call these SMART goals. So make sure it is specific. Talk about what you're going to do. Don't just say, I'm going to exercise more. Say, I'm going to start walking 10 minutes, 3 days a week. How are you going to do that? I'm going to tell my husband so that he annoys me to do it, or I'm going to set a reminder on my phone. So really make it so that you're going to you have a plan for how to do it. And then increase from there. And also it's okay to fail. You just start again. So you fall off for a week because it started snowing again. Okay, so spring's around the corner, we can get back into it.
Absolutely.
I always say, sorry, Jocelyn, I always say, have a mind like a goldfish, right? If you didn't do it for 1 week, just don't keep focusing on it. Move forward the next week and just do it.
Love it.
Yeah, and I add one more thing to that too, which is don't rush out to buy a piece of equipment that you're going to hang your laundry on, and don't rush out to get a membership at a fancy gym that you're not going to use. something that you enjoy doing, that you like doing, that you know that you can actually do. And I'll share a little personal story, but if anybody shares it, I'm in a lot of trouble. But my wife and I have talked about this for years, and I've been trying to get her to exercise, and she finally found Pilates, and she's now done over her 100 classes, and she got her name on the wall, and she's very happy about it. But the real triumph was she found something that she loves to do, uh, which took really 45 years. Again, if anybody shares that, I'm in a lot of trouble. Uh, her age, Pilates, and the number of classes. So,
No,
thing.
thank you, Dr. Neff. That's really probably the most important point about it. I'm embarrassed I didn't say that. It has to be something you like. You are never going to be consistent with something that you don't like. Otherwise, I would have run 5 marathons by now, but I hate running. So find something that you enjoy.
Absolutely. Yeah. Thank you for sharing. Okay. All right. Next question here. What BMI is considered when prescribing weight loss medication? And Erica, you
Sorry,
might.
I was stuck. My mute button was stuck. So the guidelines for our weight loss medications are a body mass index of 27 or above with a comorbidity. So 27 to 29 body mass index with a comorbidity. So that's usually cardiovascular. That can be hypertension, cardiovascular disease. There's cholesterol issues. Those are the big ones. Anybody body mass index 30 and above, that is considered by itself a reason for weight loss medications. I will say insurance plays a big role in our ability to prescribe these type of medicines now. Even though those are the guidelines that have been set for the medications, we are coming into insurances who are now saying body mass index has to be 35 and above. Or they're saying that they're requiring a lot, not just those body mass index of 30, but they have to have other underlying issues or concerns. So again, those are the main guidelines, but then remember, it is a little bit insurance dependent. But most people we can try to work towards to get the medication for them.
Okay. All right. Thank you. All right, next question here. Dr. Neff, I might direct this one to you. If you can't or don't want to take medications, what are the other options for losing weight?
Well, so I think there's a spectrum of tools in the toolbox to help people lose weight. So, on one hand, it's, the diet and exercise plan. Then it's the diet and exercise plan with a supervised provider. Then it's a diet and exercise plan with a supervised provider. And I'd add to that provider is somebody like Erica, somebody like Jocelyn, and maybe a physical therapist. Then I would add, all that plus medication, maybe all that plus medication, plus some new endoscopic tools that are just now starting to become popular. And then there's a range of surgical procedures that we have, and many of these, they sort of overlap. So I think that when a person's trying to figure out, how do I approach this? I think it starts by coming to see somebody like me, Erica, or Jocelyn, and wherever you enter into the spokes on the wheel, we can sort of direct you where you need to be.
Okay. All right. What types of health screenings are offered at Jefferson Health?
As far as like screenings for weight management, when you come to see us, we look through some of your blood work. We might determine if there's maybe a little bit more metabolic assessment that we want to do. So we obtain a little bit more of labs from you. We're working on right now, we're opening up a new location in the Navy Yard, and they are going to have one of the body composition like scales that gives you a little bit more indication as far as for your lean muscle or your skeletal muscle mass, your bone density, all that kind of stuff. It gives you more information. That should be coming very, very soon. Dr. Neff, do you do other screenings for you guys on your surgical aspect?
Oh my goodness. Well, so when the person comes into our office, we descend upon them with a navigator that guides them through a head to toe evaluation through a variety of medical providers. That's why I was sort of my head down and hiding from that question.
I know.
All right. Well, thank you. This is helpful. All right. Next question here. And Jocelyn, I'll direct this to you. This person is asking for any recommendations for best after dinner snacks.
Okay. So again, we're always going to first evaluate. Am I feeling biological hunger? Am I going to sit at the table, turn the TV off, put my phone away, and just have a snack because I'm hungry? If so, it's absolutely okay to have a snack after dinner. Generally, we're going to feel hungry every, 3 hours during the day if we're eating something filling and satisfying. So many people may eat dinner at 6 o'clock and they're not going to bed until 11 o'clock and they might get hungry in between. So you always want to be building your meal or your snack around protein and fiber and healthy fats. And so for more like snacky foods, this could look like some cheese, whole wheat crackers, and an apple. Add some peanut butter in there as well. I often like to have more of my dinner. So if I get hungry again, I'm like, cool, I'm gonna have another piece of chicken. I actually often make more of my protein and more of my vegetables so that if I do get hungry again, I can go back to it. Even if we want to have, I'm not saying we can't have yummy snacky foods ever. So even if you want to have that popcorn or those chips, we call those, naked carbohydrates. We don't want to have those types of foods by themselves. So if you want to have a bowl of chips because that's what you're craving, sounds yummy, fine, have it, again, with some cheese, have it with some guacamole, have some fruit to, add in some fiber. The problem with those snacks, like things like chips, is that we just can eat a ton of them and still not feel very full afterwards. So we can eat yummy foods, even foods that are ultra processed. We just want to make sure we're not eating them by itself. It's also going to help your blood sugar remain a little bit more stable if you're pairing those foods with the protein and fiber.
Okay. You're making my stomach grumble. I'm like, okay, it's time for some cheese and crackers. Okay. Next question here. Can I lose weight while pregnant if I'm getting the required nutrients?
I'm definitely going to direct that question to your OB and team because everyone is individual. In pretty rare cases, will someone be told that they should be trying to lose weight in pregnancy? In a general sense, in a general world, we recommend maintaining weight sometimes if someone is at a higher BMI to start off with pregnancy. So I would probably talk to your OB about what their goals are, and they will likely say, nope, you should be gaining weight, and this is what I recommend, or let's just work on maintaining your weight. It's very rare that we will advise someone to actually be losing weight in pregnancy. You want to keep in mind you are growing someone and you should be focused more on nourishing, not restricting.
Okay. All right. Perfect. Thank you. Okay. Next question here. What's a good level of protein for people throughout their life? Is there a difference in what, for example, a female who is 30 years old should eat compared to a 6-year-old woman?
Yes. Yes, nutrition, it can't be super generalized. And there's also just so many different recommendations out there for the different age groups and different sexes. And so I can't really sit here and give a recommendation for how much protein someone should have in a day because it is going to vary. It's going to vary by muscle mass and age and sex. But again, focusing on getting in enough that makes you feel satisfied. People love a number. So I will say a goal of 20 to 30 grams at a meal is usually a good place to start. But that's also going to be affected if we are on medications or surgery. And, that's not just a question for me. I don't know if Dr. Neff, Erica, if you guys want to add to that too.
I
Oh,
agree. Sorry.
yes. Do what your dietitian tells you to do.
All right. You have the green light. Okay. Next question here. Erica, this person is saying, Erica mentioned weight loss pills have a lower weight loss potential than injectables, but excluded the Wegovy pill. So could you just provide a little bit more information on that?
Yeah, sorry I wasn't more informative about that. So Wegovy, so Novo Nordisk came out with a Wegovy pill in January. That has the same weight loss indications as the injections do. It is a daily medication versus the weekly injections, but as far as weight loss in their studies, they showed that it still had that 15% total body weight loss as the injections do. So I exclude it from the other oral medications that show a little bit less of that profile for weight loss.
Okay. All right. Next question here, another kind of diet related question. Which foods or habits support fertility with PCOS?
Yeah, so fertility and PCOS is very complicated, so I would not want to give the impression that changing your diet will solve fertility problems. But again, I'm a broken record. Protein and fiber, and muscle strength training that is really vital for someone who is suffering with PCOS.
Okay. All right. Thank you. Okay. Next question. We have a few more here and then we'll wrap up for the evening. But next one here. How do I know if I have an unhealthy relationship with food that would need behavior modification or therapy? This person says, I feel as if I am never full even after eating a full meal.
I feel like I'm hogging everything. Erica, did you want to tackle that one? Go for it.
I mean, you can, but I think you've already sort of spoke about some of the symptoms and things that you're already experiencing and you're sort of aware of that. I think that your best bet would be come see me and we will talk about it and I will help you get the right sort of support that you need. But you already identified some of the issues and concerns that might be leading to some of those choices. And I do feel that, we could definitely help support you to get, the right sort of guidance with that behavioral modification.
Okay. All right. This person says, can you talk about weight loss for someone with heart failure? Any thoughts?
It's great. I do think that, as far as like heart failure, we know that there isn't like a one size fits all. You have to look at truly the whole complex medical history. And I definitely keep saying that over and over, but it is for each person individualized. We do know that some of the medications like the GLP-1s have indications for cardiovascular improvement, and they improve your cardiovascular health. So that could be something that is beneficial with those medicines, as well as we know weight loss in general helps improve our cardiovascular status. And so I think all of it could be beneficial, kind of using every sort of aspect of that comprehensive team.
Okay. All right. Next question here. How can I find out if my insurance will cover weight loss medications or other weight loss options like nutrition?
Well, for nutrition, you can always call them, or you can call the office and we can hopefully help you with that. Actually, a lot of plans do cover at least like 6 visits a year for nutrition. Unfortunately, Medicare will only cover nutrition if you have a diagnosis of diabetes or kidney disease.
Yeah, I think the thing to do in that respect is either look at your insurance company, their website, give them a call, or better yet, give the office a call. We all have staff members that can help people figure this out. This is getting very complicated for patients.
Yes. Yeah. Not fun. Thank you. Let someone else deal with that for you. Okay. Next question here. What do you suggest for someone who has tried 2 different weight loss meds and can't lose the weight they're looking for?
I think it's that comprehensive approach, right? So I think taking a step back and saying, okay, what has worked, and hearing that question too, what do you mean it hasn't worked? Like, where have you gotten to? Have you had that successful? Remember, it's a total body weight loss. If I don't know which med we utilize, but 15% total body weight loss. Did they achieve that? That's awesome. I love that. But then thinking about that additional comprehensive approach, talking about the lifestyle management program that we have with Jefferson. I mean, it can be so much more than just a medicine. You know, Dr. Neff said over and over, it's a tool in your toolbox, right? It's not the end all be all. So really working with everything else and taking a look at it. I think that approach through our team from anybody in this team could really help to kind of see what's happening.
Yeah. And looking at why we want to lose weight and why we want to lose that specific number, because sometimes it's just this number we have in our head. I've spoken with so many people who they say a specific number, and I say, how? Whoa, what? Why that number? And usually it's like, well, that's the number I was in high school. And it doesn't matter if this person is 20, 30, 40, 50, or 80. Right. So we sometimes get really stuck on these ideas. I'm seeing a lot of questions in the chat about this kind of thing specifically, like, this isn't working. How do I lose weight? How do I do this? How do I lose weight? And so sometimes, it's good. Come talk to us. We can help. But also just kind of evaluating, well, why? What are my goals, and can these be achieved with ways that don't even have to have a significant weight loss, right? So we've seen that 5 to 10% of total body weight loss can have improvements in blood pressure and blood sugar and pain levels and quality of life. It's not flashy losing 10 pounds. People are often very unhappy about that. But sometimes we have to reframe it and look at that actually as a success.
Can I add two more things to this question? Because I think it's a really good one, because there are a lot of primary doctors out there who are prescribing these medicines, and no fault of them, but they're not experts like Erica, Jocelyn, and I, who, are really familiar with these medications. How do you titrate these medications? The importance of the diet, the exercise, the follow-up. The people who lost the 15 to 20% in trials, they met with their providers weekly. They met with dietitians weekly. They had a very specific exercise plan they had to complete. People aren't necessarily getting that message when they go into their provider's office and they're asking for a Wegovy shot or a Zepbound shot. And then I would also offer to that, we are seeing as a medical community people getting different results depending on whether they're getting the actual medicines or they're getting compounded medications. You don't really know what you're getting when you're signing up for one of these compounding weight loss, places, and nothing against them. They may actually be very good, but we are seeing quite variable results than when you're getting it from, designated providers like here at Jefferson.
Okay, thank you. That's a good point. And it's a follow-up. I have another question that came in just about the weight management team. I know we've talked about it, but can you just tell us about, like, how many people make up the weight management team? Can you give us a few more details there?
Like, who's a
We
part
can all
of
say
it?
our specialties. We can say how many we have of each of us.
Yeah.
Erica, you want to go first?
Yeah, so part of the weight management team is the medical weight management. So that's part of our nurse practitioners, our physicians, our PAs. We all work together and we kind of work on that medical aspect. Within that framework, we sort of work with patients, reinforcing some of those lifestyle modifications. We work with referring to other specialties, whether it's surgery, sleep, medicine, and so on and so forth. But that's sort of the medical management with the blood work, the referrals and things like that, for where we sort of step in, with everything. And then we have our nutrition as part of our team as well. So we have both community dietitians, and then we also have our additional for Jefferson program. We have another group of dietitians. We have a behavioral therapists that actually specialize a little bit with some, eating sort of history. So behavior modification, they sort of help with that, some sort of lifestyle goal planning, those sort of things. And then, with our lifestyle management team, Jocelyn, everybody that's in there, it's like that same sort of group, but you guys focus on more too, right?
Yeah, for our lifestyle medicine team, we have 4 practitioners who are each paired with a registered dietitian to make up our lifestyle team.
Yes.
Dr. Neff, all of our surgeons.
So
Add to that, we have at Jefferson, tried to unify what we do. We're actually the first program across the Jefferson enterprise to try to unify what we do. So the Jefferson Comprehensive Weight Management Program has periodic meetings. This spans Jefferson, Einstein, Abington, Lehigh, all the various settings where Jefferson has. I lose track of how many places there are at this point, but and the regular attendance at these meetings is somewhere between 50 and 70 people between in person and online.
All right. So there's a full force of people ready to help. Awesome. Okay, a few more questions here, and then I will end the evening with one final question that I have for you all. But just a few more questions here. Okay, we have one more exercise question, which I feel like was an important one. So let's get to this one. This person says, exercise is difficult due to other medical issues and has been a big reason for weight gain. What do you suggest for someone who has minimal options for exercise?
So, first off, like oftentimes there are modifications that we can do. And there are also sometimes options in the community that we don't even know about. For example, the free library does chair yoga. It's completely free. So I would always say to look into seeing what those options are if you have certain restrictions. Is there any exercise we can do? Like what I was previously saying, anything is better than nothing. We may not be able to do exercise at this time in our lives for various reasons. And so I think that we shouldn't beat ourselves up about it and focusing on those other factors, right? We have about 6 of them that can make up if we're talking about lifestyle medicine, right? So we have nutrition, physical activity, sleep, stress, social connection, and an avoidance of risky substances, things like alcohol and avoiding nicotine. So those are 6 things that we want to try and focus on. And if one of those things, it's not that time in your life for right now, for whatever reason, that's okay. That's probably going to be the case for everyone. You know, we're not going to be focused on all 6 pillars at any one time. We're going to be addressing what we need to address, what is an issue, but also what is something that we can realistically address.
All right. Next question here, which I think we touched on a little bit earlier, but would love any additional insights you have, Erica. Does the weight loss pill have the same side effects as the injection?
Yes, so it does. It does have the same impact for the GI side effects as well. It does require, like I said, that everyday intake. It has to be on an empty stomach with sips of water. So it's a little bit more diligence with how you're taking it to make sure that it does have the effectiveness that's needed within the GI tract, within the stomach to get absorbed. But yes, it can still cause the nausea, the constipation, and all the other GI issues.
Okay. All right. One last question here. Dr. Neff, I will point this to you, which might be a big question, but let's see. There are different types of weight loss surgery. How should I determine which surgical procedure is best for me?
Oh, goodness, that's a million-dollar question, but I'll try to give you a condensed answer. I think that you will find that there are some providers in this world, some surgeons in this world, who choose the operation for the patient. I sort of try to turn this around. I think that the surgeries work differently. They fix different things. I think you got to work with your dietitian and figure out, well, what is wrong in my relationship with food? What do I need the surgery to do? And then you start to learn about the surgeries and what they do and what they don't do. And then you sort of naturally gravitate towards one of the options out there. I have this insatiable appetite. I can't figure out how to control it. You start gravitating towards the sleeve. I have this, terrible sweet tooth. I can't control it. I need an operation that helps me. You start gravitating towards the bypass. I think they're all, like cars. They'll all get you from point A to point B. Everybody drives a different car for a different reason. So I really encourage patients, work with your dietitian, figure out what's broken, what do you need the surgery to fix. I really want you to be happy in this experience, not that you came into my office and, I gave you, basically one option and you get this or you find somebody else.
All right. Well, with that, I think I will go ahead for our final question this evening as we start to wrap things up. But thank you all for such great live questions. We really appreciate the discussion. But for the final question this evening, I would love to know, what are your goals for everyone listening in on this webinar? What would you like our viewers to take away from tonight? And Dr. Neff, I will go ahead and start with you.
Okay. I was actually taking some notes. I don't know if people saw me writing on my little 3x5 card here. But my take-home messages would be the following. Surgery is just a tool, and we have many tools in our toolbox in 2026, and more tools are coming. The space is getting very cluttered. It's getting very complicated. It's not just for your primary doctor to manage your obesity. It's to go to an expert. And Jefferson has many talented experts, whether it's medicine, it's surgery, it's dietitians, it's physical therapy, it's behavioral coaching. Whatever your goals in your weight loss journey, we have the expertise to help you, both short term and long term, and that we're sensitive to the bias and stigma associated with a disease called obesity. It's not a personal failure. It's linked to over 200 different medical conditions and many cancers, and we're here to help you.
Right. Thank you so much. And Erica.
Yeah, I think kind of going off of what Dr. Neff said, I want people to realize like this is a partnership, right? It's not that old stigma about calories in, calories out. It's not about your willpower or weakness, It's really about, successful weight management. It's not perfection. I think we've stressed that. It's really working on the sustainability and working with people who can support you and utilizing every tool that's out there. We want to support you. And I hope that, you can find that with somebody, whether it's with a Jefferson team or someone else, but just learning that it's more than just willpower.
All right. And last but not least, Jocelyn.
Yeah. Seconding everything Dr. Neff and Erica have said, and, trying to move away from the promise of a quick fix. There are a lot of questions in there about what about keto, what about intermittent fasting? Lots of things work for lots of different people, but if there was that perfect diet out there, everyone would be doing it. And again, we wouldn't all be here. So it's complicated. It's hard. It shouldn't just be about the number on the scale or about our BMI. Throw out the idea of eat less and move more and focus on nourishing, satisfying, and delicious food.
Yeah, love that ending. Delicious food. Yes. All right. Well, thank you so much, Dr. Neff, Erica, and Jocelyn, for your time this evening. Such great information was shared. I know I learned a ton. And we also want to acknowledge you all for taking the time out of your very busy schedules to prioritize your health and taking that first step by attending tonight's webinar. So thank you so much. We will be posting an event survey so you can let us know your thoughts, any other specialties you would like to hear from. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. A recording of this event will also be sent to you next week so you can rewatch at your convenience. And if there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Good night.